these full arch restorations. And what we're going to do is we're going to show you how we work up a full arch, how we submit a case for surgical planning to Smile in the Box, how we perform a guided surgery, and then how we restore a full arch case. So the first case is going to be a maxillary full arch immediate load conversion. It's going to be fully guided, it's going to be immediately loaded, and it's going to be screw retained. This is our patient Judy. She has no specific medical conditions. Our surgeon is Dr. Chris Connors, and myself and James Angeloni, the denture man, are going to do the restorative part. Her chief complaint is, I'm tired of trying to save my teeth and I want implants. So we're going to do our regular initial exam just like we do on any patient. We'll do our clinical charting, our oral cancer screening, TMJ exam, perio exam, and a CBCT if it is indicated. Photographs are essential when you're doing these cases. The frontal photo helps us to determine where the teeth should be in the face, and the side view helps to tell us where the teeth should be from an anterior-posterior position. When you start to look closely at these photos, you can see that Judy most likely has a hypermobile lip, and it looks to me like she has a little super eruption of the central incisors. So her gummy smile might not be quite as bad as it seems initially, because we might be able to push those centrals up a little bit. Also very important is intraoral photographs. We take the photographs at a closed position. This allows us to see the relationship with the teeth, also measure the distance between the cervicals and the upper lip, because this is going to give us information as to where we have to put the transition line, which is where the upper screw retained prosthesis is going to stop, where the pink part stops, because we do not want to have that visible, or else you're going to have a disaster when you finish these cases. We also take a picture with the teeth open a little bit, because many times the lower plane of occlusion could be a factor. Say, for instance, the lower incisors are super erupted. It might tell us that we have to do some treatment in the lower to get those teeth down, get them out of the way, so that we can put the upper teeth, which gives us the our aesthetics, in the proper position. So at that first appointment, we're going to take impressions. It can be analog impressions or it could be a digital scan. For our full arch cases, we usually like to do analog impressions because we're able to really overextend these impressions and get all of our anatomical landmarks just like we're going to do if we're going to make an immediate denture. So we mix our alginate at the proper water to powder ratio. We use distilled water to give us a creamier mix, and we put the alginate in a syringe and we extrude it into the vestibule, so we get a nice, well-extended impression. So here's the models we got from our alginates. We have all our anatomical landmarks that we use in denture fabrication, because those landmarks are going to help to tell us where the teeth should be. And we always want to mount these cases in centric relation. Centric occlusion is just for when we're doing quadrant dentistry. Centric relation is when you're going to lose all the teeth in one or both arches. If there's a hit and slide where centric relation is not equal to centric occlusion, once you take those teeth out and the proprioception is gone, that jaw is going to drop into those fossas, and then you're going to have that patient in more of a class 2 situation. So you always want to treat these patients in centric relation. And this is an example of that. This is a patient who's got a pseudo class 3 centric occlusion, or a maximum intercuspation. You can see his lower teeth are severely in front of the upper anterior teeth in order to get his teeth together. But when we put him on a leaf gauge and get his muscles relaxed, you can see that his jaw drops back, and now he's in an end-to-end position. And if we would have fabricated his prostheses based on a centric occlusion mounting, then he would have been more in a severe class 2 situation because when we set the teeth, they wouldn't be in the right position. So again, just like all cases, before we finalize the treatment options, we're going to mount the models. We're going to look at the case when nobody's around at the end of the day. We're going to look at our photographs. We're going to look at our radiographs, and we're going to put this all together and evaluate all these different parameters, and then we're going to finalize our treatment plan. And that includes treatment plans saving the teeth if the teeth are in a good enough condition periodontally to save them. And then we're going to take the patient on a tour of their mouth at their treatment planning appointment. We're going to have the photos, radiographs, and models. We're going to present all the options to the patient, just like I showed you before, including restoring her natural dentition. And so Judy decided on doing a maxillary ProArch, extracting all of her upper teeth and doing a screw retain restoration. She would have liked to have done both arches, but financially she couldn't afford to do that. So she decided she was just going to maintain her lower teeth. We were going to send her to a periodontist just to do some treatment to try to keep those lower teeth for another few years so she can save up and maybe do a ProArch on the lower couple years down the line. So what we're going to do is we're going to take our mounted models, we're going to send it to our local lab, they're going to scan it in a lab scanner, and they're going to create an STL file that's going to go to Smile in a Box. And that's the Straumann Digital Center. We also take a CBCT and we send that to Smile in a Box via WeTransfer. We fill out a lab prescription telling them what we want to do. And then they're going to merge those two files, and along with the photos so that they can know where the teeth should be, they're going to set up an online meeting between myself, the surgeon, and the biomedical engineer, and we're going to plan the position of each tooth based on the proposed tooth positions. So when we go to the online meeting, they're going to have some tentative positions of the implants, and we'll go implant by implant, and the biomedical engineer will ask us how we like this. We might tell them to move it up, move it down. We might tell them we want a wider implant, or surgeon might say, I want to bump that into the sinus, move that up. And we just work through it step by step until we're all happy with the design of the implant positions. And from that, they will then move forward and design the guides and the conversion prosthesis. Once we have all the implants in the spots we want them, they're going to create a little form like this that tells us where each implant goes, the size of the implant. They're going to give us the information as to what parts we need for the surgical guides. They're going to tell us how much bone reduction there's going to be, and the restorative space that we have from the occlusal surface to the top of the implant for each implant site. They're going to tell us which implants to order, the lengths, the diameters, and all of the sleeves that we need to fabricate the surgical guides. And then they're going to give us a drill sequence guide, which is going to tell the surgeon which drills to use, which spoons to use, and which implants to place for each implant site. Here's a virtual rendering of the guides. It starts off with a pin guide that fits over the teeth in order to do some osteotomies for the subsequent guides. There are stacked guides and there's sequential guides. The sequential guides, each step you take off the first guide and you put on another one. With the stacked guides, you can actually keep the bone reduction guide in there and then add the other guides on top of it. So here is the bone reduction guide. You can see that it rests on a couple of the back teeth that we're going to maintain until the very end to give that guide a little bit extra stability. And you're going to see that the pins are going to go in between the implants, and anything that's hanging down from that guide is going to be removed. That's the bone that's going to be removed. Here's our osteotomy guide virtually. And here's our final conversion prosthesis that is again positioned by the osteotomy holes that we placed from the initial pin guide. So here we are on the day of surgery, patient's ready to go. We're going to place our guide. That guide has to fit perfectly. There can't be any rock. If it doesn't fit, you either need to do the case freehand or you need to abort the surgery. You can see that it fits by the tooth positions in those little windows. And we're going to have this assistant or myself hold that guide perfectly stable in place. Surgeon's going to use his osteotomy drill to position the pinholes. So he's going to drill one pinhole, and then we're going to place, excuse me, I'm going to go back. He's going to place one pinhole, and then we're going to place one of the pins in there, stabilize it, and he's going to go step by step for each of those pinholes to create the stabilization pins for each subsequent guide. In this case, this surgeon chose to not release the flap first, so he did those osteotomies through the tissue, and you can see the little holes where those osteotomies are. So we're going to take off that first guide. The surgeon is going to lay a flap, and here you go with the flap elevated. You can see how much bone that patient has. And a lot of that bone is going to be removed in order for us to hide that transition line. You can also see that we leave those two back teeth as stabilization so that the guides aren't going to rock during our procedures. The more stable you can make the guide, the more accurate the results are going to be. Teeth are removed. And then we're going to go to the bone reduction guide. So the first guide is removed, and now we have the bone reduction guide using the same pinholes that we had from the first guide. You can see here that we've sutured back the palatal tissues, because the more you can keep the tissue out of the way, the easier it is to get these guides in and out. So here we are with our bone reduction guide. You can see all the bone that's hanging down is going to be removed. Here's a little closer look. And here you can also see how closely that guide fits to those teeth. No space between the teeth and the guide. You can see in this case, we're going to be removing about 8 millimeters of bone. So, you know, a lot of times the surgeons are hesitant to do that, but if you don't follow the plan, you're going to end up with lack of restorative space and a weak restoration. And we really need these restorations to not crack during the healing period, because we don't want any micro movement, or we're going to jeopardize the healing of those implants. So here we go. Our bone reduction is complete. And now we're going to do the osteotomies. So the bone reduction guide is removed. This guide is placed using the same pins. And now we're going to use these spoons into those metal cylinders, and we're going to go follow the drill sequence and go drill by drill, expanding the diameter of the osteotomy, and then finally placing the implant through the guide. And what you'll see here on the angled abutments, which the posterior ones are usually angled, we're going to have to line up the little vertical line on the carrier with the black lines on the guide. This is going to replicate the timing of the implant so that that angled abutment is going in the right direction, so that when we go to pick up our final prosthesis, the abutment is within the holes of the prosthesis. So here we are with our implants placed. Most surgeons will kind of fill in some of those holes with some bone grafting material. And the next step that we're going to do is we are going to use our bone profile to remove any excess bone around the implants that might prevent our angled abutments from going into place. If you don't do this, sometimes those angled abutments won't seat, and you're just fighting and you just can't get get the abutments in place. So this takes away the excess bone and allows us to place those angled abutments. We're going to place our SRA abutments, and these are going to be torqued to 35 Newton centimeters. And these are going to be what the metal cylinders that we pick up our prosthesis are attached to. And this is what it should look like. The little carrier handles that you use to place the SRA abutments should be relatively parallel. And then therefore the cylinders are going to be parallel. And so when you go to pick up the prosthesis, you're not going to have to open those holes up and weaken the prosthesis, because again, we do not want this to break. We use these little cotton tip applicators many times. We just break them and they fit perfectly in the cylinders. That way the acrylic doesn't go down in the holes. The conversion prosthesis is held in place by the stabilization pins. And then what we are going to do is we're going to inject a pickup material. This happens to be Quick Up. There's many different materials such as Stellar or Chairside Reline that can attach the prosthesis to the cylinders. We're going to let that set for several minutes. The material is self-curing, and once it's set, we're going to remove the little applicator tips, unscrew the prosthesis, take away the stabilization pins, and there we are. You can see how the rubber dam material that we put over the cylinders protects the abutments and the flap from getting acrylic down there and creating a problem that we have to clean out, or acrylic that might stay in there that you don't